Okay. Well, welcome. We are doing our last pediatric neurology echo session for today. We have Catherine Zixes, our pediatric neurologist, who is joining us today, and we're specifically discussing anti-epileptic drugs. And I know, even since I've done my training, that the options and myriad of choices out there has far exceeded my level of comfort. And so we're happy to have her here to help engage us in a discussion over the latest and greatest information on our anti-epileptic medications. We have two cases to present for today. Karen Sketsina is going to be presenting the first case. Go ahead, Karen.
Okay, sorry, I had you on mute because I have a few first-year medical students. They're just getting settled, but I'll go ahead and present the case. So this is a case of a 4-year-old male who has had 2 seizures in the past month. So during both these episodes, he looked blank for a few seconds, then stiffened all of his extremities, and his eyes rolled back. Each episode lasted about 1 minute. The first episode was about a month ago. The second event was 1 week ago. The family could not identify any triggers or provoking factors for these episodes. We did start him on Keppra last week after the second seizure event. And after the first seizure event, he was prescribed Diastat by the emergency department, so they do have that at home. He also had a CT scan after the first seizure event in the emergency department that showed no acute abnormalities, and an MRI has been scheduled, but not yet completed. He's also had an EEG, which was a normal awake study. He's not had any other workup. Otherwise about the patient, he is in preschool, he's doing okay, keeping up with his peers, sleeping okay according to his family. His past history, he was a full-term baby, born by C-section for failure to progress. There were no complications during pregnancy or delivery. His developmental milestones have been on target so far. His other past medical history, he has a history of gastroesophageal reflux, no relevant surgical history. Family history, he does have an older sister with history of 1 simple febrile seizure in the past. So my questions. He was started on Keppra last week, as I mentioned, after his second seizure. His family says that he's been extremely moody since starting the medication. They say he becomes upset and frustrated very easily, and this is not at all like him. He's usually a calm and easy to get along with child. So my question is, could these mood changes 1 week after starting Keppra be related to the medication? Is this normal? Will it improve? Is there anything that can be done about it, or do we need to switch him to a different medication?
Yeah, so I think this is a really great case. I'm sure that most people who are kind of participating today have probably had a case almost exactly like this. I think this is by far the question that we get asked the most about folks who have just started a seizure medicine, with this one being so commonly used. So I think to discuss your first question, is this normal? So when you start levetiracetam or Keppra, the most common side effect by far is going to be mood changes. And we try to do a little bit of anticipatory guidance with families. They're already freaked out, they're already upset, their kids had a seizure, 2 seizures usually, at least when we're starting a medication. And I try to tell them ahead of time, it is going to take about 1 to 2 weeks for your kid to get used to this medication. So I think what you are describing, this kind of change, he's a little moody, he's a little upset, it sounds like he's functioning, but they're just kind of having a rough week, is very much within what we normally see. And what I typically tell families is, please, unless the kid is tearing your house down, please try to give it about 2 weeks. Most people, when they come back to clinic, will say after about 2 weeks, things did get a lot better. So I think your question about, do we need a different medicine? What can we do? Before we move on to a different medicine, if these changes do persist for longer than about 2 weeks, we often will recommend a trial of vitamin B6 in addition to the Keppra. And now many of you may have seen that in cases or patients that you have. The dosage of that is 50 to 100 milligrams a day. The evidence for it is actually quite anecdotal. There are some papers and people who will say their behavior turned around 180 degrees. It's so much better. And there are people who say that it doesn't do anything. But I do think a good trial is worthwhile. The reason, and we'll talk in more detail later about the different medications, but the reason are a couple things. One, this particular medication, Keppra or levetiracetam, is extremely user-friendly for our little kids. This little guy is 4 years old. This is not a medicine that you need blood levels drawn periodically or that you have to have frequent laboratory studies to keep up with it. This is not a medicine that doesn't come in it does come in a solution, so you're not crushing pills. There's all kinds of kind of positives. It's a very forgiving medicine, which we'll talk about later in terms of if you forget a dose, those sorts of things. And so it's not a medicine that I like to throw out super easily if there is a chance to kind of overcome the side effects. I will say that in a small percentage of cases, and I don't think this necessarily correlates with people who have an underlying behavioral or psych history. I do not always see that correlation at all. There are a small percentage who literally get psychotic on the medication. So if you have a kid who has been on it for 1 week and they are tearing the house down and beating up their little sibling, then yes, they might need a different medicine. But in the case of, I'm a little upset, I'm frustrated easily, I cry a little bit, those sorts of things, we do encourage families to kind of try to overcome that. So I would ask your particular family to give it about 1 more week, kind of see where things are the side effects tapering off? And if not, at that point, I think that the vitamin B6 piece could be a good kind of temporizing measure if the medicine is doing its job from a seizure control standpoint. Did that answer your question?
It does, thank you.
Do we have any other questions from anyone else regarding the case that Karen just presented? I definitely know it's a problem I see often in my patients who are new onset seizure disorders who are started on Keppra. That's one of the most common concerns that I see. So that's helpful to at least have a hang in there for 2 weeks and then consider vitamin B6 if that is not working.
Yeah, and I do tell families also, if it's not to the point of psychosis or a really serious issue, I also tell them all medicines have side effects. This medicine has the least side effects of many of our medicines. So, you're not going to progress onto something that has less side effect options. And so given that we know you need a medicine, I feel like sometimes in that setting, kind of thinking about it that way, they're also more willing to continue it for a little bit longer.
Great. Any other thoughts or questions? Okay, well, we will move on to our next case presentation. Go ahead.
Can everyone hear me okay? Okay. This next case is about an 11-year-old male who presents to an acute care clinic, although he has been trying to establish with a neurologist for quite some time. He has been having seizure-like activity that's described as episodes of jerking of the upper extremities, which are rather forceful and downward in motion. That last about 3 to 5 seconds. He was having these about 3 to 4 times a day, but have really gotten worse, and now having 5 to 7 episodes per day. And this is despite up titration of his seizure medication by the primary care provider. No known provoking factors or triggers for the episodes. Currently, he's being treated with carbamazepine. He's been on this for years, hasn't seen neurology in quite some time. The pediatrician who's taking care of him has been up titrating the carbamazepine recently in the setting of these increased seizure activities. He does have diastat at home, though. In terms of previous head imaging, he had a head CT in the NICU years ago, but the family doesn't really know the results. The EEG that has been done was ordered by a PCP about 2 days ago, and it showed generalized 2.5 to 3 hertz spike in wave bursts. Otherwise, there's no other laboratory work that's been completed on this patient. In terms of development, the patient has a delayed learning. He is in 5th grade, but has IEP and is in special education classes. The patient sleeps okay. In terms of his birth history, he was a 27-week infant, a twin gestation. He was preterm labor, 4-month NICU stay, including a, quote, brain hemorrhage, but that's really all we have. In terms of a developmental history, he has a long history of delay. He does not walk. He cannot feed himself. He can put some sentences together, and he does converse and interact with his family, but otherwise a significantly delayed child. In other terms of past medical history, the brain hemorrhage that was mentioned, he also has a diagnosis of cerebral palsy, epilepsy, and a VP shunt that was last revised about 5 years ago. And then there's really no contributing family medical history at this time. So the first question for this case would be, in the setting of worsening seizures, despite up titration of the medication, carbamazepine, what are suggestions about optimizing this patient's management? Should we continue to increase the carbamazepine, or should we be picking a different medication?
Okay. So I think this kid sounds like has a little more past history, a little more complicated maybe than the kid that we just talked about. The first thing I will say is I'm a neurologist, so I see seizures, okay? And it does sound like these episodes are seizures. But the only thing I would say in the setting of increasing medications, first off, is what is the status of his VP shunt? So that is the only other thought as you're kind of presenting the case. You're going up on medicines. He's still having seizures. The seizures are getting worse. Is the shunt okay? Given the history that you told me, I do have some recommendations, and I think that I see a potential issue that may explain kind of what's going on from a neurologic standpoint. But I do just want to point out to everyone, certainly all of these complicated kids with these premature histories are very complex, and a lot of different things, certainly can trigger a story like this. What I heard you say that I think is the most interesting is that he's been on carbamazepine for a very long time. It sounds like our history is very limited in terms of why that particular medication was chosen, what sort of EEG findings or seizures he was having maybe way back when that medication was chosen. But the EEG information that you told me that he had the other day, you told me generalized spike wave burst, I believe 2.5 to 3 hertz. The reason that is interesting is because that description could go with the type of episodes you're talking about, the forceful jerking of both upper extremities. But that particular medication, the carbamazepine, would be a very poor choice for that EEG. And the issue is that particular medication could cause that EEG to get worse. Okay, so what I'm hearing is that we have a medicine, and we're going to talk briefly here in just a few minutes about these different medicines. But I'm hearing that you have a focal medicine is what it is. And like I said, we're going to talk about it, and that we're treating a generalized problem with that. And I think that's where your issue is coming, that not only is the patient not improving in terms of his seizure frequency and sort of thing, but he's actually getting worse. And so I think probably backing up completely in the setting of this new EEG information and potentially picking a totally different medication might actually be helpful. And I think that this is a big pitfall, which we will talk about as I promised. There are a couple of different medications that can get primary care providers in trouble when they're not as aware of all of the details, which they shouldn't be. You guys are not going to know all of the details about every medicine. And so later on here, I do want to point out a few that you could potentially make the patient worse, so that we can prevent kind of doing harm for the patient. Most of them are going to be fine, but this is one of the kind of top 3 that, if it is chosen incorrectly in the wrong patient, might actually make things worse. So I think in your patient's case, it sounds like probably many choices that would treat a generalized epilepsy, but that this one in particular is probably not the best choice. Do you have any other questions about him, or about, did that make sense?
Yes, it does, especially looking at it from an acute care perspective. You come in with this limited history, kind of what do you need to make a decision about the med list that you're given?
Correct. And that's very frequent. I mean, people present for transfer of care to primary care providers. They show up for a sick visit and they have 50 other problems. I mean, we've all been in that situation. And I think just being aware of where you can go wrong in terms of making things worse, if you kind of are comfortable with some basic things that you can at least keep the patient together until you can get some more detailed neurologic input, is really kind of the learning point, I think, for this case.
Any other thoughts or questions on that particular case before we do move into the slides? And hopefully Dr. Sixties will lead us through which are some of the medications indicated for focal seizures and then for generalized seizures, so we can make sure to have that distinction in our brain.
Would it be applicable to check electrolytes on a patient like him with abnormal brain and other things? And, you know, I don't know if carbamazepine causes any electrolyte changes, but.
Yeah, I think it would be relevant. Typically, when we think about a chronic epilepsy patient, we don't necessarily first think, are electrolytes okay? But in a patient who's having that much trouble getting them under control, I think just like going back to the drawing board and thinking about the VP shunt, I think spreading out and thinking a little bit about, is there really something else going on? I think that's totally appropriate. Carbamazepine, as every drug, which we're going to talk about in the slides, but every drug has a list of everything, right, that it could cause. Major electrolyte imbalances are not its major side effect, but if you have a kid that's literally, in this case, out of control, I would not at all think that that's a bad idea to kind of back up and say, are we missing something completely different here?
Okay, well, we'll go ahead and delve into the slides, and there Dr. Sixties will go through each of the medications, whether we need to be monitoring labs or not, because that was something we did regularly 15, 20 years ago, and a lot of the newer meds, we don't need to monitor any kind of electrolytes or CBCs or anything like that. And then we'll have an opportunity at the end to ask some specific questions about these medications or anything else that you all may have online. All right, go ahead.
All right, we're going to get it pulled up here. I will say, just to start with, there are many, many, many anti-epileptic medications. I picked out the ones in this slide that I think you most commonly see from an outpatient general pediatrician perspective. This certainly does not include every medicine that you're going to see in your most complicated epilepsy patients at all. And the other kind of caveat I would say is I have gone through here and kind of practically given you some guidelines in terms of laboratory studies to follow, things that are certainly very important. If you look up all of these medicines, there's not always a perfect consensus on it. If you look in UpToDate, for example, and you look at labs that you could or should follow, there are often many things listed for all of them. So what I've tried to do is kind of point out what most neurologists are doing in terms of the side effects that are most commonly seen, to give you a little bit of guideline instead of just that list of 1,000 side effects and 1,000 labs. So it's a little bit more practical. I hope that's my goal. So I have nothing to disclose. So real briefly, let's talk about the treatments of epilepsy, because as Dawn pointed out, you know, it's for many, many years, there were very few treatments, and that has really exploded in the past little bit. And here we are going to focus primarily on maintenance medication. So this is kind of an outpatient focus. This is not a patients in the hospital won't stop seizing. Okay, this is familiarity with medicines that we're going to see for maintenance. And I do want to say that in addition to many, many anti-epileptics that really have improved in terms of how well they work and how many choices there are a lot of non-medication options that have come on board as well to just be familiar with, to know of. One is the vagal nerve stimulator, which is well in use. It's been well in use probably for 15 years now. That literally attaches to the vagus nerve. It sends off little pulses. They have a magnet they can swipe to send off a bigger pulse when a big seizure is happening. So that may be something you see a seizure patient talk about having. This RNS, responsive neurostimulation, is a new thing. I'm not even sure that it's really in play, except maybe at the biggest epilepsy centers. It is an implant in your brain that treats partial seizures as well. But if you see in the future or hear about that, that's kind of what's coming down the pipeline with that. The ketogenic diet is a very high fat, very high, low carb diet that does significantly help a lot of patients. So you may see a patient on that. It's a very restrictive diet, so certain patients need to be very kind of carefully selective. Sometimes patients may have had or be worked up for a surgical resection if they have one abnormal spot in their brain causing all their seizures. And then a corpus callosotomy you may see in a very bad off epilepsy patient. It is not it doesn't fix anything. It's a palliative surgery. They literally cut the anterior portion of the corpus callosum to prevent primarily drop attacks. So one side of the brain seizes, it doesn't spread to the other side. It's more of a quality of life issue. So in addition to the medicines we're going to talk about, there are more medicines and there are other options besides medicines. So anti-epileptics have really exploded. They've exploded to the point that, back in the 60s and the 70s, there were maybe 4 medication choices. And now we have 40 or more medication choices. We don't use all those on an everyday basis. They're not all on this slide. They continue to come out every 6 months. And it's really to the point that some of the medicines are primarily used just by epilepsy specialists, not even by general neurologists. There are so many to choose from at this point. So as I said, we're going to talk about maintenance medications, that some are going to be useful for many seizure types and some aren't. We're going to point that out as we go. This is the list of some that we're going to talk about. We're going to start off with the ones we can use for all types of seizures. Some choices are better than others, but for you guys from a primary care perspective, I want you to feel comfortable with these are generally okay for any type of seizure until I can get some additional neurologic input. And then the bottom 3, and I'll point them out when we get to them, are very specific and you could actually hurt someone if you use them incorrectly. As I said, there's plenty of others on the bottom that you may see patients on, and they're continuing to be developed every day. So in this presentation, this is kind of a setup. We're going to talk about the common uses, the formulations that are available, the side effects that you may see, not the whole list, okay? It's definitely not a pharmacology discussion. It's really more things that I tell people when I'm prescribing a medicine, things that I actually see. Scary side effects that we definitely don't want to miss. Pearls for pediatrics, and then basic monitoring things. Again, the general consensus sometimes definitely does vary. So first we're going to talk about our favorite, the one that we hear about so often, and you guys I'm sure are all familiar with, and that's levetiracetam or Keppra. Remember, for our purposes, we want to think of this as a medicine that can treat all different kinds of seizures. So don't focus on memorizing partial and generalized, just focus on all types of seizures. It can be helpful, at least to some extent. It comes in tablets, a suspension from the pharmacy. There is a dissolving form and an extended release. The suspension from the pharmacy makes it especially helpful for our children. It's pre-made, it's always in the same concentration. It really reduces confusion. There's also an IV form. You'll notice when we go through here that there are only 5 medicines that have really nice IV forms. And so that is also helpful if you are coming into the ED. Common side effects, which we discussed, behavioral changes by far are the ones that are the most common, but behavioral changes to the level of psychosis are possible. So it is very real if a parent complains of that. As we discussed with the one case, vitamin B6 anecdotally can be very helpful. I would say about 50% of my patients probably thinks it helps and 50% think it doesn't help. Sometimes I start with 50 milligrams if it's a smaller kid. Sometimes I go up to a bigger amount if it's a big kid to start with. And for Keppra, there are no labs that have to be monitored routinely. Also a really big perk when you're talking about a 2-year-old who is coming to clinic every 3 to 6 months. So let's talk about topiramate or Topamax. It is also used very widely for multiple things, but often for epilepsy. That's really its primary indication. It also treats all types of seizures, okay? So that's our take-home point for this particular one. It comes in tablets and an extended release form as well, but also in sprinkles. So the sprinkle capsules are kind of the key point for pediatrics for Topamax. We certainly can compound the solution, and we do. You know, that's not going to help you when it's 8 o'clock on Friday night and they need to start the medicine. So the sprinkles, you can put them in applesauce, you can do, you know, whatever they'll take it in, often works very well for our kids. Cognitive side effects are one of the major complaints, especially at higher doses, but can be at low doses. It's usually higher level thinking, like I'm having trouble finishing my math homework the way I used to, not I can't remember how to brush my teeth sort of thing. People will also complain of sometimes paresthesias, a little numbness, a little tingling in their fingers or their toes on this, decreased appetite, and sometimes decreased sweating. So great choice for a kid who's already overweight. Maybe not a good choice for a kid who is struggling, who's already seeing gastroenterology for that. I do tend to shy away from this particular one in patients who are complaining of numbness and tingling already. Maybe I'm wondering about MS if it's a little older teenager level patient because of this side effect of numbness and tingling. And then the sweating piece is not usually an issue unless you're talking about like a football player doing 2-a-days in July or something like that. Most of them, it's just stay well hydrated and there's not an issue. Scary side effects, they can have kidney stones. I do not prescribe this medicine to a patient who has a personal history of kidney stones. And I also want to make people aware of the acute glaucoma risk. Very small risk, but the reason I bring it up is we often get phone calls for all kinds of reasons from little kids. They're holding their eyes, they're rubbing their eyes, and most of the time we don't think a lot about it. We say watch it. But if the kid is on Topamax or topiramate, that is maybe something to take a little more seriously or ask a few more questions about than we might otherwise. They can also have some metabolic acidosis, usually fairly mild, but typically this will be seen in a patient who comes into like an ICU setting. They're on Topamax, they have a little metabolic acidosis, and people kind of say, what's going on? This is what's going on. So this is kind of where that came from. Usually it's nothing that is clinically relevant to the patient. So in pediatrics, the ability to sprinkle it in the food makes it wonderful. And the fact that it does not need routine lab monitoring also makes it a very good choice. So this is often one of our top second choices, sometimes our first choice, depending on the situation. Our next choice is zonisamide or Zonegran. And I like to say that topiramate and zonisamide are cousins. Zonisamide is the weaker cousin of topiramate. Okay, so this one and the one we just talked about are cousins, and this is the weaker cousin. Again, it's going to work for all different kinds of seizures, at least to some extent. It comes in a tablet and has to be compounded into solution. So this is where it kind of falls off in terms of being a first choice for some of our younger patients. The biggest side effect by far is sedation, and therefore we often recommend giving it only at bedtime. It has a reasonably long half-life. Sometimes people can't, it doesn't fly and it has to be divided into twice a day, but it does. So often people will get by with just taking it at bedtime. It again does not need routine monitoring labs, which makes it lovely, why it's still third on our list of choices in pediatrics. It is a sulfa drug, technically, and that makes it different from topiramate and essentially most of the other medications as well. The studies that have been done do not suggest that people who have a sulfa allergy to other medicines really have a reaction when they take this. So there's a very small crossover with that, but technically it is, and I feel like that's something you should know kind of going into it. Okay, so we're going to move to kind of a little stronger level medicine. We're still talking about medicines that treat all kinds of epilepsy, okay, and we're going to talk about valproate or Depakote. This is obviously one of the older ones. I think most people have heard of it. It comes in tablets, it comes in sprinkles, again, very nice for younger kids. It also comes in a solution. That solution is called Depakine by the name brand. It comes in an IV form, all right, so it's only the second one so far that we've seen that has an IV option. Side effects that are really a big deal are weight gain and appetite. I have seen kids gain 50 pounds on this medicine, in a year, okay? So this is a huge deal, and so you do want to think about monitoring that and maybe not picking that in the most overweight kid up front. At certain doses, people also have their hair fall out. I've seen it happen. They can have pancreatitis. I've also seen that happen. They can have low platelets, elevated ammonia, and trouble with their liver. So this medication is stronger than the medications we just talked about. It is a great medication. There are patients who need this medication to be controlled, and if so, that's fine. We'll do the monitoring that we need to do. But it certainly is a little bit heavier of a choice once you go down this pathway. We do not recommend using this ever in people who have metabolic problems or are less than 2 years old. There is an increased risk of liver failure in that population, so we try to never use that in these folks. There's also a risk of neural tube defects, so that gets to be a significant problem in our 16-year-old females who have epilepsy as well. In pediatrics, these are a couple of pearls. Ammonia can be elevated and will be elevated when you are taking Depakote. If your mental status is okay, we see ammonia levels into the low 100s. And so if it is not over 100, we do not get excited if you are on Depakote and mentally thinking okay. You can try levocarnitine supplementation. Neurology often talks about trying it if the ammonia is over 100, and that's to kind of help the liver process the medication a little better. The other pearl is the solution, the Depakine. If you're going to use the solution, it does come in a pre-made solution from the factory, which is good, but it has to be given 3, really 4 times a day is how it's indicated. So sometimes people come and they've been changed to solution. They've been dosing it twice a day. They've had more seizures. This is why, because it has to be given much more frequently, which is very not user-friendly. Definitely needs monitoring labs, as you can see. So a CBC, LFTs, often a level, and often an ammonia will be gotten about every 6 months unless there's concern in the meantime. We're going to move on and talk about lamotrigine. I think about lamotrigine and Depakote as also kind of cousins. They don't necessarily work the same way, but they're both kind of big gun medications that treat all kinds of epilepsy. So we've kind of moved up here. We had Keppra, we had topiramate and zonisamide, and now we have valproate or Depakote and lamotrigine. This one also treats all different types of epilepsy. It comes in tablets. There's a chewable form, which is nice. There's an extended release, and they've made a dissolving one as well. Solution still has to be compounded. By far, the most common side effect is going to be a non-serious rash. The scary side effect we all talk about is Stevens-Johnson rash, but I will tell you, if you look at every single one of these medications, Stevens-Johnson rash is listed on all of them, okay? So it's not definitely going to happen or definitely not with this particular medicine. In pediatrics and in all areas, adult too, this medication has to be up titrated very, very slowly. It takes approximately 3 months to reach a starting dose of this medication. It is a great medication. It is a very clean medication. It does not have a lot of side effects, does not have a lot of mental side effects in terms of thinking. So great choice, but takes a very long time. We do typically monitor CBC. In the past, we have always monitored LFTs. Some people have gotten away from that in more recent times. But I think you can see the difference between these two. Both great medicines. This one has fewer side effects, not as many scary side effects if you get past the rash for sure, but this one takes 3 months to get to a starting dose, and the Depakote can be loaded IV. So that's kind of your difference in choosing one over the other in these patients. Who needs it and how fast do they need it? Are we doing okay? Do we need to stop and kind of back up on any of these 5 medicines? It's not the most interesting topic, so I tried to make it more useful, okay, in terms of day-to-day stuff. All right, so we're going to talk about a few that are a little less common in outpatient life. So the first is Onfi or clobazam, also a medicine that works for all different kinds of seizures. does come in tablets, and in the past 5 years or so, they have come out with a pre-made solution for it. By far, the most common side effect is sedation. Drooling can also be a significant side effect. This particular medication is a benzodiazepine, but it is made differently than the others. So the other ones, so Klonopin, Ativan, all of those, work at the 1,4 chemical bonding, and Onfi is 1,5. That's why it's called Onfi, 1,5. So it works differently. It has a longer half-life. Its addiction potential is different, although you would still never stop it suddenly. In pediatrics, because of the tiredness issue being the major issue, sometimes we have to dose it up to 3 times a day. However, we often will dose the nighttime dose higher. So we may have like 5, 5, and 10, and that higher dose at night makes them sleepy, but kind of last into the day to keep the level up. Again, if you look this one up, there are some different recommendations on monitoring it. I do not do labs routinely, and the neurologists that taught me did not do labs routinely for this particular medication. Lacosamide or Vimpat is coming into the pediatric world. It is more common, actually quite commonly used right now in the adult and kind of teenage population. It is, as many of these are, studied for partial onset, but if you use it in all kinds of epilepsy, you're not going to make things worse, okay, which is what our take-home point is. We have tablets and solution to choose from. It also comes IV, so again, a good thing for the hospital. At high doses, people will complain of dizziness, so that's kind of your upper level. We've reached our upper limit. Side effects that are concerning: it can prolong the PR interval and cause problems or cause 2nd to 3rd degree heart block. So if you have a patient who already has these issues, this would not be the medicine for you to pick in this case. I do not see this a lot in people who are less than teenagers. I have seen 1 or 2 neurologists start it as like a first-line drug in children. I don't know if they don't see a lot of children. It's a little bit of a strange choice to me. Typically when I see it, typically when I use it, it's a teenager who has exhausted these other options, and we've kind of moved up to this. It's definitely best studied, more at least anecdotal evidence in teenagers than younger kids. Same thing as the others. I do not routinely do labs for this and do not know other neurologists that routinely do labs for this. All right, so a throwback to a couple of kind of old school ones before we move on to the ones that are for different uses. Phenobarbital is still around. It is very old. You know that we use it in the NICU, but occasionally you'll see a kid that is continued on it for whatever reason. Maybe it's the only thing that worked. They've been on it for 15 years, whatever. It also works for all different kind of seizures. Comes in a tablet, comes in a solution pre-made from the manufacturer, and also comes IV, as we know. So now we've picked up, I think, our 4th IV drug that we have. Sedation, by far, again, the biggest issue and something that we have to watch. But long term, when you're using this medication, we get worried about cognitive development. So back maybe 20 years ago, people would be started on phenobarbital in the NICU. They would be sent home and kept on it for about a year. And they would then wean off and say, you had a neonatal seizure. Now, if that is the case, if someone is sent home on phenobarbital, we try to switch them over to something less cognitively impairing, like Keppra or other related medicines that we've talked about, by 2 to 3 months of age. So seeing someone a year or 2 out, it's either because they failed that switch and we've made a risk-benefit discussion, or because they need to see a neurologist and get switched, okay? Because long-term cognitive development is not good. So we definitely focus on doing that. A level can be helpful. Again, we rarely use it in outpatients long-term. So in terms of long-term monitoring, you know, I don't really get levels a lot because I don't use it a lot. But if I do see someone with it, I would kind of want to know where I am to get a sense of how well it is being utilized in the body. Now we're going to talk about phenytoin or Dilantin, also one of our older medicines. Also will work for all different kinds of seizures. Tablet, solution, chewable, and IV. So here's our 5th IV medicine. And I do think, even though the focus here is maintenance medications as an outpatient, I do think it's important to realize how few IV medications there are. Because sometimes people talk to patients and they say, you can never take Keppra again, or you can never take whatever again. And sometimes when those patients come into the ED, then the families struggle to allow you to give them this medication via IV. And I do think just some anticipatory guidance about you may need this in an acute crisis can be helpful, because again, the choices are very few. And so if you need it, you need it. Long term though, if you're using phenytoin, you do get some significant side effects. Gum hyperplasia that's very notable. You will see nystagmus and ataxia are seen when the levels are high. Okay, so if you're overdosing or you've taken too much, you'll see that. But long term, you can get cerebellar atrophy. So you can get issues in that vein long term as well. When you load an IV medicine, should the patient come in, you do need to be aware of three major things. One is hypotension. So a patient who's come in with a spinal cord injury, who you need to keep their blood pressure up, this is not going to be a good choice. When you're IV loading, not taking it orally, you can also get arrhythmias. So a patient who's come in coding or something of that nature might not be the best choice. Purple glove syndrome is also an issue. And the issue with that is that when this medication is given as phenytoin and it comes out of the IV, you get the picture that you see on here, which is called purple glove syndrome. It literally kills the tissue in that area. So when the neurologist says you need to load phenytoin or you need to load Dilantin, it's usually what people will say, what they really mean is you need to load fosphenytoin. Fosphenytoin is a precursor. It's then broken down very quickly in the body, but if it should come out of the IV should blow, it would not cause this side effect. So just kind of a safety issue there. So as I said, it's rarely used long-term as a medication, although we do sometimes. Another pearl to know besides the purple glove is that we often see increases in seizures in ICU patients or hospitalized patients when their medicines are converted from IV to NG. And the reason is because this medicine gets stuck in the feeding tube and they do not get hardly any of it. So all of a sudden you've gone from what you thought they were getting to them not getting much of it at all. This particular medicine is probably the most important to monitor a level, both inpatient and outpatient, because of its very narrow therapeutic range. It has zero order kinetics, meaning that all of a sudden you get just slightly over the dose that you need and the level will shoot up. And you'll start to see nystagmus, ataxia, things like that. This medication is also affected by albumin. So knowing the free level in addition to the total level can be very helpful because the free level is really what's acting in the body. So if you have someone who does not have normal albumin or normal nutrition, then getting both of those levels can be very helpful as well. Okay, any questions about any of those so far? Because we're going to change gears here for just about 5 more minutes. Okay. So the next 3 medicines, the last 3 medicines that we're going to talk about are ones that you do want to remember that they have very specific uses. If you have determined that it's the appropriate medicine, they are great medicines, but they are medicines that inappropriately chosen can make the patient worse. And that's the last thing we want, especially if you're just trying to get them started on something, to get them to neurology. You definitely don't want to make them worse, right, in the meantime. So oxcarbazepine or trileptal is the first one. It is for partial onset seizures only. So if a patient has a brain tumor or they've gotten an EEG and they have all these angry sharps from one spot on there, this is a great medicine for that. But if not, for those generalized things, like we talked about in our case earlier, not the best choice. Comes in tablets, does come in a solution pre-made from the manufacturer, does have an extended release version. People will complain again of being dizzy, especially at high doses sometimes, and you can get a rash when you're initiating the medication. Scary side effects are going to be low sodium. You can have development of problems like SIADH, and again, this can make the generalized seizures worse. We often don't worry about the sodium level. It's usually in the low 130s. It's one of those, they come into the hospital, you do their labs, why do they have sodium of 131? This is why, and usually it's causing no problem at all, okay? So usually, unless it is way below, well into the 120s, we really don't get that excited about it if the patient's doing well. Some people will check sodium every 6 months on these patients. Some people will not. The reason is because there's no trend to the development of these abnormalities. When we think about Depakote, we think about your platelets, for example, trending down over time, and I'm following that, I'm watching it. In the case of this, if the sodium is going to drop significantly, it often drops significantly without warning, and that may not happen at your 6-month checkup. That may happen anytime. So if a patient calls in with concerns and is on oxcarbazepine, the first thing you should think about is checking sodium. But doing it just because they're at your office is not necessarily going to prevent anything. The next one is the cousin. Okay, so again, we have these two medicines that are cousins. We have oxcarbazepine and carbamazepine, which is an older version. It is a stronger cousin, but of course it has more side effects. It also is for partial seizures only. So if it's a partial onset, great medicine. If not, can make your seizures worse. Comes in chewable, solution, and tablets again. So a lot of these medicines do come in solution, which is helpful. But in addition to knowing that you're not going to use it in a generalized problem, this particular medicine also does what we call auto-induction at 1 month. And so you may have talked to the neurologist and they're going to see him in 2 months and whatever, and things are going really great. And you guys have decided to start this medicine. And then about a month after it started, all of a sudden the patient starts having 1 million seizures again. And you think, what happened? Things were going so well. So this particular medicine has to be increased at the 1 month line. Basically, you can schedule an increase because of the auto-induction that takes place in the liver. It chews itself up to the point that it has to be adjusted to kind of reach a new level. There are some scary side effects: agranulocytosis, suppression of multiple cell lines, liver problems, and again, makes generalized seizures worse. I am a younger neurologist, so I will say that oxcarbazepine gets the job done, has fewer side effects, and needs fewer blood draws. I know that there are some older neurologists that would be highly upset that are just very dedicated to this medicine they've used for a long time, but I rarely use this medicine in light of the availability of the other one with fewer side effects. If I were using this medicine, I would check LFT, CBC, and a level, kind of at checkup appointments to make sure we weren't trending in the wrong direction with any of these things. And then lastly, we're going to talk about ethosuximide, which I'm sure you're all familiar with as well. Ethosuximide, or Zerontin, that's always confusing because zanisamide is a different drug completely. It treats absent seizures with 3 Hertz spike wave generalized discharges. I do want to make the point about this. We've talked about it in some of our prior echoes where we talked about different seizure types. This is one of those tricky situations where you treat a staring spell with this medicine, but the staring spell is a complex partial seizure, does not have a 3 Hertz generalized spike wave, and you make the patient's seizures worse. So remember, if you've got an EEG and they sound like absents, they look like absents, and they have the standard 3 Hertz spike wave that we've all heard, great medicine. But if not, this is the wrong medicine for the patient, okay? It does come in a solution in tablets. It's a little tricky because the tablets only come in 250 milligrams. So if you have a patient of in-between size, sometimes we end up with, well, 1.5 tablets is too much, but 1 is not quite enough. And sometimes you will see like 9 or 10-year-old patients on solution of this medicine for that reason, because we need to kind of reach an in-between level. Biggest side effect people complain about is GI or abdominal discomfort. For that reason, sometimes we divide twice-a-day dosing into 3 times a day dosing, just so they're getting smaller amounts, and we always encourage them to take it with food. Often, that will take care of the problem, and so you can continue on the medicine because it is a good medicine if chosen correctly. Do remember that in addition to not, being the wrong medicine and making things worse, if someone has absent seizures and other types of seizures, as we've talked about in prior sessions, this will treat the absent seizures wonderfully, but it will not treat the other seizures. So you would need a second medication for that. So the pearls, I think we may have talked about most of them, but the pearls, the liquid form can be helpful to give you an in-between dose. Taking it with food can be very, very helpful. And then dividing it into TID dosing can be very helpful. Same thing with this monitoring as with a couple of the others. Traditionally, people did CBC and LFT. Depending on where you look and who you ask, some people don't do LFTs now, but typically will do a CBC for screening. And I believe that that is it. of a long and somewhat cumbersome, but hopefully helpful highlights for that topic.
Ready for questions?
Yeah, sure.
Is there ever a role for Keppra levels? You know, I'll see people come in and they'll have these levels drawn. How do you judge, you know, dosing? You know.
Yeah.
That's just a question. Yeah.
Yeah, that's an excellent question, because I feel like people come into emergency departments or urgent care settings with a breakthrough seizure, they get a Keppra level drawn, and then what do you do with that, right? That happens all the time. So really good question. I never say never, but I essentially never draw a Keppra level. I almost never request one. The only time I really draw a Keppra level is if I want to catch someone being non-compliant. That's when I draw a Keppra level. If the patient is within the dosing range of normal dosing that's described in the literature and the studies that have been done, and they are not having side effects, they are fine. If you're having side effects, you need less medicine. If you're still having seizures, you need more medicine. And that is how I dose Keppra. So really the level, I only use it if I am trying to confirm that they are not taking their medicine, or they're not taking it as they've said they are, those sorts of things. Otherwise, it's a send out lab. It takes 4 days to come back. They're going to be discharged from urgent care by the time it comes back. And I think it's mostly a waste of money, honestly.
And along those same lines, I know you didn't address dosing per se with all of these medicines, but we do often, as the primary care provider, have the kids come in, they're on their maintenance Keppra, and for the last few days, they've had several breakthrough seizures. When do you consider adjusting the dose of Keppra when you don't necessarily have levels to go on, but you have increase in symptoms, and then sorting out, is this related to something else that's going on? Or is this a need for increase in medication?
Yeah. So if they clearly have not taken it, they clearly missed several doses, I don't increase it. If they are clearly very sick, they have the flu, they've had 3 viruses like everyone this month, if they are really in that department, I don't necessarily increase it. I will say, even though technically those are times we don't increase it, if someone missed 1 dose and they had a 20-minute seizure, or they had the world's smallest illness and they had a 20-minute seizure, sometimes I will adjust it, just because if you're that borderline, if you're that close to falling off the cliff, maybe you do need a little better buffer. So traditionally we say, if you're sick, if you didn't take it, if you threw it up, we know why you had a seizure, don't adjust it. My kind of little thing to that would be, if you're that close to the cliff, like, let's give you a little extra boost. And then usually we're going to recommend adjusting it if you are doing what you're supposed to, minding your own business, not sick, not having a problem, but you're having a seizure. And in the case of Keppra, and I know that I'm coming back to that one because I know pediatricians often use it the most, which is a good choice. It treats all different types of seizures that we've talked about to some extent, at least well enough to give you a starting medication. And that particular medicine, you can always adjust it a little bit, okay? Even if you're really at the upper limit, it will never hurt to give 10 per kilo extra of Keppra to try to get through to next Monday's neurology appointment, okay? So that, like I said, is a very forgiving medicine for parents too, which is why I say if they've thrown it up, you can give it back completely. So it's a very forgiving medicine. So yes, if they are minding their own business, doing what they're supposed to, and still seizing, they always need an increase. If not, it kind of comes down to how, you know, do I really think it's just because they had a really bad infection or something like that caused it? Did that answer the question? It's a little bit of a complex answer.
Yes.
But yeah.
No, that was great. Yeah. Other thoughts or questions as we're reaching the 1 o'clock hour?
Do you give your patients a lot of anticipatory guidance of if they get a GI bug where they're vomiting like 2-3 days? You know, well, that time they're probably in the ER, but you know, the ER calls us saying, oh, the patient needs to be admitted because, you know, breakthrough seizure because they didn't be able to take their medications, you know, but do you really need to admit them, or can they get an IV dose of medication? Especially with Keppra, if I'm led to believe correctly, the PO to IV version is very 1-to-1.
It is.
That's something, you know, think about.
Yeah. So I think that there is room for discussion about if they need to be admitted or not. If they clearly have missed 5 days worth and they've had 30 seizures, yes, admit them. If they're dehydrated, nutritional status, that kind of thing, admit them. The thing that I would say is if it's 1 or 2 doses, you can reload it and put them back on their medicine. I do give them anticipatory guidance. I have a sheet, actually, it's called a seizure action plan, just like an asthma action plan that I made up. And it literally says if you throw up your medicine within 30 minutes, based on the medicine that you're on, you can repeat a full dose or you can repeat a half dose. With Keppra, the answer is always a full dose, okay? Because again, very forgiving, not gonna hurt you if you get a little bit extra. The other thing that you can think about, which is a little tricky depending on insurance, is Klonopin, because it does come in a dissolving tablet form that you can put in the cheek. So sometimes when we have patients with major GI bugs that really don't need to be admitted, we will give them like 4 doses of this dissolving Klonopin, again, if insurance will pay for it, because we know that they're going to get it. And the same thing is true in the hospital. If the patient gets admitted and you have the same problem, you can schedule a short-term benzo if they can't keep it down, you know, if you couldn't give it IV or whatever the problem, depending on the medicine. So sometimes we will give them that to say, take this tonight, tomorrow morning, and tomorrow night. Try to take your Keppra if you can, you know, to keep your level where it needs to be, but this will bridge you, is what we call it, bridging you through the illness, basically, to get to where you can take your normal again. So there's definitely things you can do to be creative, to not just have to admit them, to give it via NG or IV.
Well, thank you all so much for joining us. We are still in the process of determining our specialty for the next echo session that we'll hopefully have in the next month or so. If you all have any burning suggestions, let us know by email. We would love to hear from you. And thanks so much for joining us.
Thanks, Catherine.
Hey, guys.
Now, Brian, Cassie Hudson was watching, but I never could see her name. Yeah.
For a couple, I felt like I couldn't see all of them. Like maybe they were, you know.
You can hide people that use a phone. Like if they fractured for to call in.
Mhm. Mhm.
Yeah, and there are more people than that, for sure.
Yeah. Some of them, it's almost like